Welcome to Decoding Healthcare Research. Join us as we delve into the behind-the-scenes world of groundbreaking research and the dynamic healthcare industry, interviewing top paper authors, engaging experts on industry-related topics, and exploring medical subjects that affect our daily lives.
Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E. Efrain. I am an associate professor of anesthesiology at the Medical College of Georgia. Today, we are going to answer or try to answer a question based on the evidence. And this question has been asked multiple times in this podcast. I will phrase the question as, what is the effect of the ketogenic diet on the lipid profile and cardiovascular risk? To answer this question, I'm going to start by giving a little bit of background. So we know that the lipids are transported in the blood attached to lipoproteins. So the process starts with the lipids that you ingest in your diet, both cholesterol and triglycerides. They are broken down by different enzymes in the GI tract. And as they get absorbed by the intestinal epithelial cells, they are reconstituted into cholesterol and triglycerides and put together with an apoprotein to constitute the chylomicron. The chylomicron is the first lipoprotein that we are going to refer to here. And this one, once it is absorbed, is going to go to the bloodstream and travel to the adipose tissue, where the triglycerides can be released and stored in the adipose tissue by the action of the lipoprotein lipase enzyme. So the remnant of that chylomicron has cholesterol in it and is going to travel to the liver, where it is incorporated, and the process for now stops there. But at the same time, the liver has the ability to create a new lipoprotein with cholesterol and triglycerides that is called VLDL, or very low density lipoprotein. This one has, in addition to these molecules of fat, it also has an apoprotein called apoprotein B100. So the VLDL is then released to the circulation, and from there, it travels again to the adipose tissue, where again the lipoprotein lipase is able to release the triglyceride, most of it. And then the remnant of that VLDL starts traveling in blood and becomes what is called intermediate density lipoprotein, or IDL. This IDL has triglycerides and also has cholesterol, but that cholesterol can be enriched further by the action of the high density lipoprotein, or HDL, which is called the good cholesterol. So the HDL has another apoprotein that is called apoprotein A1, and it has a lot of cholesterol. So this HDL can donate cholesterol to the IDL to make it LDL. So you see here how the HDL becomes like a buffer to try to keep the cholesterol in good levels, if you will, because it's going to regulate how much cholesterol is going to give to the LDL cholesterol. So this pretty much closes the cycle for the lipids. So the first thing to note here is that the lipids cannot travel on their own. They have to be always attached to an apoprotein as part of a lipoprotein so that they become soluble in blood. So these lipids that are traveling as part of these lipoproteins can potentially be deposited in the blood vessels. But that doesn't happen spontaneously. There are two preconditions that you must have in order for these lipids to actually get deposited there. One of them is that there must be an inflammatory process already happening, systemic inflammation, and there must be also like exposure of proteoglycans from the subendothelial surface to which the LDL cholesterol can be attached. Actually, the LDL cholesterol has affinity for these proteoglycans. So if you don't have any of those two conditions, the lipoproteins are going to just travel in the blood without causing any problems. So we need to understand then that the LDL cholesterol is not triggering the process. It's part of the process. It becomes part of the process. If you have those two conditions that I mentioned before of exposure of subendothelial proteoglycan and systemic inflammation, then this LDL gets into contact with the blood vessel, then the macrophages that are surrounding that blood vessel are going to phagocyte those lipids and make part of an atheroma that can potentially be associated with cardiovascular disease. So there is clearly an association between the LDL cholesterol and different types of fat and cardiovascular disease. That relationship is not necessarily causal, but they travel together, if you will. So that's important. So we have a total cholesterol. We have cholesterol in the form of LDL, cholesterol in the form of HDL, and there is also, as I mentioned before, remnants of cholesterol after the chylomicrons and the VLDL lipoproteins are unloaded of triglycerides at the level of the adipose tissue. And there have been interesting studies showing that the remnant of cholesterol is in itself a risk factor for cardiovascular disease. It's also important to remember that there are multiple studies uh, giving evidence about the relationship between the different levels of cholesterol, triglycerides, and cardiovascular disease. So I'm going to start talking about each one separately. First, let's talk about total cholesterol. So the World Health Organization has categorized total cholesterol as a significant risk factor for cardiovascular disease. So there is an interesting study published in Frontiers of Medicine in 2021 by the group of Dr. Dong. He prospectively studied during 10 years a cohort of patients, finding that the risk for ischemic heart disease was highest if you had a total cholesterol of less than 155 or more than 185. In the scientific reports of 2019, Yi and his team evaluated a huge cohort of 12.8 million patients in China, and they found that the lowest mortality was associated with a cholesterol level between 210 and 249. Similar results were found by the British Heart Foundation and the World Health Organization in 2005. They studied populations from 64 countries, and they found that the lowest mortality occurred with total cholesterol between 200 and 240. And it's interesting because we normally focus only on the high cholesterol, but there is evidence that low cholesterol is also associated with cardiovascular risk. Now let's move on to LDL cholesterol. Well, LDL cholesterol has been shown to have a U-shaped curve with higher cardiovascular risk at low LDL levels and also at high LDL levels. Interestingly enough, with less than 70 with less than 70 of LDL or more than 160, we see a significant increase in cardiovascular risk and cardiovascular death rates. However, only with the LDL levels below 70, you see an increase in all-cause mortality. Again, low levels of fat seem to be risky from the cardiovascular standpoint and also in terms of all-cause mortality. And this was published by Dr. Kim and his team in the journal Cardiovascular Diabetology in 2023. There is an interesting study in 2018 that is actually a landmark study nowadays, published by a group in Sweden led by Dr. Ranskov. So he basically started analyzing meta-analysis reviews regarding the association between cholesterol, specifically LDL, risk and the effect of statins. And he found that there were significant cases of bias in which studies with negative results were excluded and they used misleading statistics in some of them. So he started questioning the causality between LDL levels and cardiovascular disease. And that opened the window for new studies, again, questioning that not the association, but the causality between LDL and cardiovascular disease and death rates. Let's continue talking now about triglycerides. Well, the same study in Frontiers in Medicine by Dr. Dong showed a linear relationship between the levels of triglycerides and ischemic stroke. So we are now not only focusing on general cardiovascular disease, but the effects on the central nervous system. They found that with level of triglycerides of less than 80, there was also an increase in the risk of death by all causes. So this is similar to what has been observed with total cholesterol and LDL. And he actually argues that it's probably better to analyze the triglycerides in the context of the cholesterol presence. In other words, the ratio between triglycerides and HDL should be considered. And if you want to be more specific, then the ratio between the apoproteins for each one of these two is also important. So the ApoB in relation to the ApoA1 is a good indicator, a good marker of cardiovascular risk. So this can give us a broad idea about the real association, not causation, between the different types of fat and cardiovascular disease. Now let's move on and let's talk about a ketogenic diet and the lipid profile, which is the question that brought us here today. So the first study that I want to show was written by Dr. Lee and his associates and published in the BMC Endocrine Disorders in 2022. So this is a randomized controlled trial that included 60 patients to receive either a ketogenic diet with 75% fat content, only 5% of carbohydrates and the rest proteins, versus the standard diabetic diet that is restricted in carbohydrates. So they randomized these patients who were either overweight or obese, and all of them had diabetes type 2. So they found that the total cholesterol was less or was lower in the ketogenic diet group, as well as the LDL, which was also lower. The triglycerides were lower. There was a better control of diabetes with lower levels of hemoglobin A1C and fasting insulin. They also noticed a significant decrease in weight in the patients who received ketogenic diet. And at the same time, they observed that the levels of uric acid were higher in the patients with this diet, and there was poor adherence to this regime. So the two aspects that are important regarding this study are, first, that the effects on the lipid profile are linked to the changes in weight, and also that the lack of adherence to the ketogenic diet may be a serious limitation to the implementation as a therapeutic option. So there is another study by Garner and his team in 2022, published in the American Journal of Clinical Nutrition. This is also a randomized controlled trial that included 23 patients with either prediabetes or diabetes type 2. They were randomized to receive either ketogenic diet or a Mediterranean diet. So they found that the ketogenic diet was able to reduce the levels of triglycerides, increase the levels of HDL, and also had a greater weight loss. Uh, Between the two groups, one of them, the Mediterranean diet, decreased the weight in 7%, whereas the ketogenic diet reduced the weight in 8%, 1% difference between the two. More importantly, the LDL levels in the ketogenic diet group increased in 10%, whereas with the Mediterranean diet, the LDL decreased 5%. So there is a difference of 15% between the two dietary options. So the one aspect that is important in this study is that the adherence to the diet was significantly better with the Mediterranean diet. And this is a common theme when we discuss a ketogenic diet. So maintain this diet may be difficult, finding the right ingredients, keeping the right distribution of macronutrients is sometimes difficult to achieve, and that's again a limitation of this type of diet. Let's move on to the study by Chavo in 2022 in the journal Obesity and Surgery. They evaluated patients with obstructive sleep apnea and they randomized them to ketogenic diet versus standard American diet. And they found again that all the lipid profile was way better with the ketogenic diet. But more importantly, the weight loss was significantly greater again with the ketogenic diet. And the question arises again. Does the weight loss improve the lipid profile, or is it the way around, the other way around, or they are independent from each other? That's a question that hasn't really been resolved yet. And in this particular case, the OSA improved as the weight loss decreased, and that is in favor of the ketogenic diet. In 2021, in Clinical Nutrition, Dr. Vidic published an interesting study because this one was not in patients with obesity or diabetes. They actually used ketogenic diet in trained young men, and they assigned these individuals to one of two groups. One was ketogenic diet, the other group was just plain caloric restriction. And they found no differences in terms of lipid profile, so no improvement with the ketogenic diet. And that makes us think that probably the maximum benefit of ketogenic diet in terms of weight loss and also in terms of the lipid profile can be seen if you have a premorbid condition of either overweight, obesity, or diabetes mellitus. So there is another study that was conducted along the same lines, published in Nutrients 2021 by Dr. Buren. This randomized control trial enrolled 24 women, and in the crossover, they randomized for the order of the assignment to ketogenic diet versus standard American diet. And they found that the ketogenic diet was associated with a higher level of LDL, both small density and high density molecules, whereas the apoprotein B was also higher in the ketogenic diet group. In this case, in this particular study, there were no changes in weight loss. And again, this can be in line with the general observation that for you to have a significant changes, positive changes in your lipid profile with ketogenic diet, probably you have to have a weight loss at the same time. So there is another study trying to evaluate something similar here that was published in Nutrients 2020 by Dr. Michelsick. He evaluated women who were overweight and obese, and they found that everything improved except the HDL level. So again, the LDL was lower with ketogenic diet. In this case, the weight dropped significantly. And again, this is reinforcing the idea that for you to have benefits in the lipid profile, weight loss has to be present. Now, based on this series of randomized control trials, there is no consensus about the real changes in the lipid profile. As I mentioned before, in some studies, the LDL actually goes up. In some others, it goes down. So let's go to the meta-analysis. So there are two that stood out in my analysis. One of them was published by Dr. Rafula in 2022 in Nutrition Review, and the other one by Dr. Yuan in Nutrition and Diabetes 2020. They found that consistently HDL goes up, LDL comes down, and triglycerides also come down with ketogenic diet. So in other words, when you take all the studies into consideration, the effects on the lipid profile by the ketogenic diet doesn't seem to be negative, actually seems to be protective. In some studies, it has been shown that the changes are transient, and after 1 year staying in ketogenic diet, the lipid profile tends to go back to baseline. But this is anecdotal, and for now, I would probably base my analysis on all the clinical trials that I mentioned, and also this couple of good meta-analysis. So what are the conclusions and what are the recommendations based on this, trying to answer the question that brought us here today? So first of all, that there is no conclusive evidence despite the significant amount of clinical studies underway and that have been completed to date. But despite that limitation, we can still make some recommendations. The first one is that we have to prioritize weight loss when we use a ketogenic diet, because we know that that weight loss goes hand in hand with the improvement in the lipid profile. So it's interesting to have this into account, because the ketogenic diet has been seen as one of the cornerstones nowadays to try to implement plans for weight loss, and is definitely useful. However, we have to understand the significant limitation of compliance and adherence with this type of diet, and that requires probably a lot of education and encouragement as well as coaching when someone embarks into this type of diet. So again, to summarize, lipid profile and weight loss go together. And when we use ketogenic diet, one way to monitor our progression is to monitor the weight loss. Finally, we need to understand, based on the evidence, that ketogenic diet is able to improve insulin sensitivity, and that is reflected in a better control of hemoglobin A1C, better fasting glucose control, and over the long term, probably reduction in cardiovascular risk. I want also to point out that most of the studies have been focusing on lipid profile and weight loss. However, there is a significant lack of studies evaluating cardiovascular risk in the long term, and this has to do with the short follow-up time for the majority of these trials. And this is definitely a knowledge gap that needs to be filled by future research. So that is, in a nutshell, the list of conclusions and recommendations that I was able to draw from my judicious analysis of the current literature. I hope this answered the question, even though we are left with new questions, which is a good thing, because in the end, that is fuel for additional research. I hope you enjoyed this summary, and see you in the next episode of Decoding Healthcare Research.
Thank you so much for tuning into this episode. If you enjoyed it, please don't forget to give us a thumbs up and share it with your friends and family. Make sure to subscribe to our channel and hit that notification bell so you never miss an episode. If you have any questions or thoughts about today's topic, we'd love to hear from you. Feel free to leave your comments down below. For more information and references related to today's discussion, you can find them in the video description below. We appreciate your support and look forward to having you back for our next episode.